So I'm doing the Pulmonary Journal Club this week, and I'm going to be reviewing the Lantern and Flame trials. So I have no disclosures. So just a little outline. I'm going to go through a little background and relevance for these studies, review some of the pertinent literature leading up to these studies, obviously then review the studies, and then we'll have some discussion and conclusions and talk about application to our clinical practice. So a little background is, we all know COPD, our bread and butter disease, is a progressive disease with persistent airflow limitation, with respiratory symptoms, and is associated with chronic airway inflammatory response. It's a major cause of chronic morbidity and mortality worldwide, and it affects greater than 5% of the U.S. population, and is currently the third leading cause of death in the U.S. And in 2010, costs the country in direct and indirect costs about $50 billion. So a lot of significance. So diagnosis is centered around symptoms of dyspnea, chronic cough, sputum production, gradual decline in activity, and history of exposure to known risk factors. And then obviously spirometry with a post-bronchodilator FEV1 over FEBC less than 0.7, or using a threshold based on the lower limit of normal, as people's ratio tend to decline with age, so it's thought that this may overdiagnose elderly. So, very familiar graphic to all of us, I'm sure. The previous GOLD guidelines, how we began to group patients in A, B, C, and D based on their risk of their airflow limitation based on spirometry, either GOLD 1, 2, 3, or 4, their risk of exacerbations, and then their symptoms, choosing whichever risk was the highest and then putting them into a category and helping to direct our therapy from there. However, as you're all probably aware, there's been new GOLD guidelines that have recently come out that advocate for dividing out the spirometry and the exacerbation and symptoms. So you no longer will use the spirometry to put someone in an A, B, C, D category. You would more likely report them as a group A with GOLD 2 or something like that. But all the treatment is still based on the A, B, C, D. So it's kind of taken as a separate entity. So another common assessment, just kind of going through some of the assessments, and I'm going to go through some questionnaires of COPD, is the BODE index, which just helps to predict 4-year survival. So it has 4 different components to it, with a grading of 0 to 3, the maximum score of 10. It just gives us a little bit of an idea of a 4-year survival, so it can be helpful when we're assessing our COPD patients, especially when we have a new patient in clinic. And I'm just going to run through, not in too much detail, but I just think we should all be kind of aware of some of the more commonly used questionnaire symptom assessments that are out there with COPD. The more commonly used ones that we frequently use in clinic are the CAT, or the COPD assessment test, and the Modified Medical Research Council, which is part of the GOLD criteria with classifying people. St. George's Respiratory Questionnaire is used in a lot of studies, as well as the Baseline Dyspnea Index and Transition Dyspnea Index. So we've all seen this form on the left of this, the CAT, which we frequently give to patients in our clinic, and then we can review when we see them. On the right here, just as a quick review of the MMRC, which is a very quick, easy inpatient clinic, which everyone does, even directly or indirectly, if they don't use the same words every time they see a COPD patient, St. George's is a little bit more complex. It has 50 items and a score of 1 to 100. Higher scores indicate more limitations. And then this is a little bit more complex too. This is the clinical COPD questionnaire, used a little bit more in research as well, with 10 different questions and scale of 1 to 6 of each of them. And higher score is worse. And then the Baseline Dyspnea Index and Transitional Index, it came up in a lot of the papers I reviewed, so I decided to include it. And it's assessed basically like it says at baseline, and then the transition is basically assessing the change in your symptoms, and it has 3 different categories and 24 items. And the lower the scores, the worse the dyspnea. This I just included because I thought it was kind of interesting, and something I hadn't really come across too much in the past, and I just like the schematic kind of, and I think that it might be useful to some patients. You kind of throw this piece of paper down in front of them, and they're supposed to mark an X on that 10-centimeter line of where they become more breathless, and I think it gives it just a little bit of more of a graphic picture of how people's symptoms limit them. called the oxygen cost diagram. So then getting back to treatment and relevancy of these studies, this being the older GOLD guidelines with the treatment recommendations based on your grouping. As you can see, in most of our patients, obviously more likely are in the group C or D, which frequently we start out with inhaled corticosteroids and long-acting beta agonist. So this is from the new GOLD guidelines, which is reflective of a lot of the study. Well, it's in agreement with the studies I'm going to go over, but there's previous studies that it's kind of formed from, where no longer in group C and D is it recommended to start with a combination including an inhaled corticosteroid. But depending if you're C or D, starting with either a combination LABA-LAMA or a single LAMA, and then potentially escalating to a combination, depending on symptoms. So just quickly, the rationale of dual bronchodilation, because these two studies, you probably know, which I'm going to get into, are focusing on dual bronchodilation with LABAs and LAMAs. So obviously it makes sense. There's two different pathways they work on, so you would expect to get better bronchodilation working on two different pathways, as you can see on the left. The muscarinic, anti-muscarinic blocks binding of acetylcholine, so then leads to relaxation, muscle relaxation. And then on the right, where the LABA works, the pathway with increased CMP leads to relaxation as well. So I'm just going to kind of quickly try to review and go through a lot of the LABA-LAMA combination trials that kind of led up to our study. So this is a study done in 2015, or published in 2005. It was a 3-center randomized double-blinded 3-way crossover with only 71 patients, so pretty small, and they had to have an FEV1 of less than or equal to 60. And as you can see on the graphic on the right, over time the FEV1 was measured, and you can see the highest one being the combination treatment of tiotropium plus formoterol, and the other two either being just formoterol or just tiotropium. And obviously there's, a significant improvement in the FEV1 with the combo. The next study published in 2006 was once again a 3-center randomized crossover trial with 3-way crossover with LAMA versus LAMA-LABA combination once a day, and then LABA-LAMA combination twice a day. Which basically showed, once again, as you can see the graphic here, an FEV1 improvement with the addition of the LABA to the LAMA. On average, the FEV1 improved 200 milliliters with the combination and the BID dosing of the formoterol. And you can see the second spike in the graphic, which makes sense because that's the one with the BID dosing of the formoterol. Moving on to a trial published in 2009, once again multi-center, and this was a parallel group instead of a crossover. Had 234 patients. Their requirements were an FEV1 less than or equal to 65 and an MMRC greater than or equal to 2. So symptomatic patients. This one looked at the area under the curve of the FEV1 and showed over a 24-hour period that it improved from baseline more with the combo by about 220 milliliters. The next one I'm going to go on to was published in 2010. This was another crossover, 4-way crossover, done with LAMA versus LABA versus LAMA-LABA once a day and LAMA-LABA twice a day. I'm going to get tongue twisted here, which once again kind of validates what we've seen. This is also a small study, but showed that the combo was superior to monotherapy only by an average of 72 and 90 or 97 milliliters, though, so not like a huge margin. And then moving on to this study done in published in 2011. This was actually a meta-analysis of 8 different randomized controlled trials of over 1,800 patients. In all, the average FEV1, FVC, trough FEV1, and mean TDI, which is that transitional dyspnea index, all had statistically significant improvement. So kind of moving into now what our study drug is going to be, this QVA 149, which is indocaterol and glycopyrronium, which I'll go into a little bit more in detail when I talk about the studies. And this one was, once again, a randomized controlled trial, and it was a 4-period crossover and had 154 patients. And their criteria was GOLD 2 and 3 COPD. And once again showed that the LABA-LAMA combination had better bronchodilation than just the LABA alone, as you can see on the graphics. And it used the trough FEV1 that you can see on the right here at day 1 and day 7. So now I'm going to jump into getting closer to our trial. As you guys might be aware of, there's this group of Novartis sponsored trials called the IGNITE Clinical Trial Program. It's all focusing on this study drug, which our trial is based on, which I talked about, is the indocaterol and glycopyrronium. It is a combination of 11 different studies over several years and includes greater than 11,000 patients in 52 different countries. So I'm going to review a couple of these as we go on just briefly, but the ones that obviously we're going to really review today are the Lantern and the Flame. You can see up at the left there, top. So in this, and you'll see a little flame clip art in the lower left to let you know that it's part of the IGNITE trial. So it just kind of like clarified things for me. I don't know, it's just a little indicator. So this, using the study drug, was published in 2013. This is the SHINE trial. It included over 2,000 patients with GOLD 2 and 3. And then it showed that there was a higher trough FEV1 at 26 weeks compared to LABA or LAMA alone. So it was a little bit longer than a lot of the other trials I went through. Some of those were only like a week or two. So, you know, half a year, 6 months, not too bad. It randomized people to 2 to 2 to 2 to 2 to 1 placebo, as you can see here. So the placebo will be in the 1. The study drug, and then the 2 components of the study drug, and then tiotropium. So then you can see from the graphic here, compared to combination compared to either of the components or tiotropium by itself, there was a significant increase in the trough FEV1. And you can see the primary endpoints there. We're comparing the 2 study drugs, and there was an increase or change in the trough FEV1. Still was only about 70 to 90 mL. So not like a huge amount, but it had statistical significance. And just in case anyone doesn't know, the trough FEV1 that I've been kind of mentioning throughout here is just measured right before the next dosing. And it's important for BID dosing to make sure you're getting a good, accurate number instead of just throughout the day. Okay, so then moving on once again, this is another one that is part of the IGNITE trial series. This is the BLAZE trial, also published in 2013 in a 3-period crossover versus the parallel in the previous. This had only 247 patients with GOLD 2 and 3, and this one looked at dyspnea scores at 6 weeks. And using the BDI and the TDI. So in this graphic on the right here, you can see the TDI, so the change, the transition dyspnea score, was improved in the study drug versus tiotropium. But if you actually look at the actual change from placebo, I mean, it's 1.37 points, so it's not a huge difference compared to the rest. So getting into the next trial part of the IGNITE is the SPARK trial. This was also published in 2013, also a very large one with greater than 2,000 patients, and did parallel groups with patients who were a little bit sicker. They were GOLD 3 and 4 and had to have at least one moderate exacerbation in the last year. And these were, like I said, it was parallel, so they were randomized 1 to 1 to 1 of either the study drug, tiotropium, or glycopyrronium. And it looked at the annualized rate of COPD exacerbations and found there was a reduced rate of moderate to severe by about 12% compared to just glycopyrronium alone, and a 10% reduction compared to tiotropium, but this wasn't actually statistically significant. All right, moving on quickly, I just have a couple more to review before we get on to our main trials we're going to talk about. Leading up, now there's some studies that are LABA-LAMA versus ICS-LABA, which is what our study is going to be, so I just wanted to kind of review what else was out there prior. So in 2008, this study was published. It was multi-center, double-blinded, parallel group with about 600 patients with moderate COPD. This one looked at the area under the curve of the FEV1 and the peak FEV1, which found an improvement in the group with tiotropium plus formoterol versus the fluticasone plus salmeterol. So, as you can see, the dark line there is the combination, and below the combination LABA-LAMA, and then below is the salmeterol fluticasone. One more, I think this is the last one before our trials in the IGNITE series. So this is called Illuminate, which was published in 2013 with about 500 patients, and their FEV1 40 to 80%, and had to have no exacerbations. So a little bit less sick than some of the other studies. This one found, it compared the trial drug that we're going to talk about versus salmeterol fluticasone. And as you can see, it looked at the area under the curve for the FEV1 over 12 hours, as you can see the graphic on the right. And at 26 weeks, you can see that it was 0.138 higher in the study group. I thought throw this in here too, just because a lot of the trials I've been focusing on what we're talking about is going to be talking about the study drug as a combination, but we do have, LABA-LAMAs that have been on the market for a little while now. This is well known as a neuroellipta, which is umecolidium and vilanterol, and this compares it to fluticasone and salmeterol. So this was published in 2015. Included about 700 patients with an FEV1 of 30 to 70 and MMRC greater than 2, but couldn't have any exacerbations. So this looked at a weighted mean of from 0 to 24 hours of the FEV1 and found it to be a little bit higher, but only about 80 cc's higher. One more with this same combination comparing what we know as a neural and Advair. This one was actually done with the 250 dose versus the other study that I just talked about was done with the 500 dose of Advair. This is actually two studies, each with about 700 patients with FEV1 30 to 70 and MMRC greater than or equal to 2 and no exacerbations, and found a change or an improvement in the FEV1 weighted mean of from 0 to 24 hours of about 74 cc's and about 100 cc's. In the two separate trials. All right.
So,
yeah.
All the studies leading to the NAC trial, all their outcomes was based on improvement in FEV1, but no hard outcomes such as exacerbation.
Yes, I didn't find any with exacerbation. Sometimes they looked at some secondary, but I don't think that any of them fulfilled that. And then there was a couple that looked at like dyspnea scores and symptom type stuff, but not exacerbations. So finally now we're into the actual studies of interest. So the Lantern trial was a randomized study published in 2015. It was a 26-week, multi-center, randomized, double-blinded, double-dummy, because they couldn't really disguise the different delivery mechanisms of the two different inhalers, parallel group. Patients were collected data on them from 2012 to 2014. They were randomized 1-to-1 to either indacaterol, glycopyrronium, or our study drug, I'll just call it, once daily at the 110/550 dose versus salmeterol fluticasone or Advair at the 500 dose twice a day. So it's kind of interesting the way they did this. They had a washout period for a week, and then they had a 2-week run-in period where they kind of assessed patients' eligibility, and they didn't get, this study compared to the next one, they didn't lose a lot of people at that point before randomization, but the the next study I'll talk about did lose quite a few in that time period. So going into patients and inclusion criteria. So inclusion criteria, male and female patients greater than or equal to 40 years old, moderate to severe COPD classified as gold 2 to 3, MMRC greater than or equal to 2, so more symptomatic patients, current or ex-smokers with at least 10-pack year smoking history, and FEV1 basically between 30 and 80, which is just kind of redundant with the gold classification. So exclusion criteria, there's a lot. I'm not going to read through all of it. This is kind of some of the general exclusion criteria that makes sense. I mean, someone who's pregnant, nursing, any kind of contraindications to the medications, any kind of underlying medical diseases that could be an issue with anticholinergics, with the narrow angle glaucoma or BPH, people who had uncontrolled diabetes, or other kind of clinically significant comorbidities. And they were kind of generic with this. They just said people who had very, as deemed by the investigators, had clinically significant other comorbidities and listed a bunch of kind of examples. But it seems like that's probably a lot of our patients. Anyone who had malignancy in the last 5 years except basal cell was excluded. And the inability to use an electronic diary, because that's how they got their symptoms and assessed for exacerbations and whatnot. And anyone with a BMI over 40. And then the COPD-specific exclusion criteria, which I think is more important, and I kind of highlighted some of the ones that I thought were of more interest. Anyone that had more than one exacerbation requiring treatment with antibiotics or steroids or hospitalization, so either a moderate or severe exacerbation, in the last year or within the last 6 weeks prior to randomization. These people were able to be screened again if they'd had one in the past 6 weeks, and then enter the trial, but they couldn't have one in the past 6 weeks at all. Anyone who's on oxygen more than 12 hours a day, someone who had a significant decline in the FEV1, which they measured by at least 20% during that run-in period, anyone who had, other pulmonary diseases like bronchiectasis or fibrosis or active TB. I mean, these all kind of make sense. Lung transplant patients, people who had lobectomies or LVRS were excluded. And then another important one is, history of asthma, which I think is obviously very important for this study because we're looking at inhaled corticosteroids. Or they even said anyone who had respiratory symptoms prior to the age of 40, so with a suspicion that maybe they had underlying asthma. And then anyone who had eosinophil count greater than 600.
Yeah, I wonder if some of the exclusion for the asthma patients is because you'd be giving them a labo without an ICS.
Oh, yeah. Yeah, for sure, yeah. So the assessment, what they did, they collected spirometry data at day 1, week 6, 12, 8, and 26. On days 1, 12, and 26, they did a 45 and 15-minute pre-dose spiro, and then a 5, 30-minute, 1 hour, 2 hour, and 4 hour post-dose, because that's going to help us with our area under the curve data, as you'll see going forward. Their primary outcome was to demonstrate non-inferiority of the study drug to this abbreviation here, SFC, is our cimeterol-fluticasone, in terms of post-dose trough FEV1 at 26 weeks. Their secondary objective was to determine superiority of the study drug in terms of the FEV1 area under the curve of between 0 and 4 hours at 26 weeks. And some other secondary endpoints that they looked at were peak FEV1 and FVC, trough FVC, that TDI score, the transitional dyspnea score, St. George's respiratory questionnaire score, and they looked at these at 12 and 26 weeks. Some other kind of exploratory objectives they mentioned were CAT scores at 12 and 26 weeks and COPD exacerbations. So this one was really mostly a spirometry-based study, and it was a non-inferiority. So just going a little bit more in depth about the statistical methods. So it was a non-inferiority margin was assumed to be negative 60 mLs. This was based on treatment difference between placebo and, I'm just going to call it Advair, of 160 after reviewing Cochrane, or in a Cochrane review with a confidence interval of 95% of 120 to 200. So taking basically the lower half of that bound is negative 60, which is a common way that the margin is come up with. So using those above assumptions, they needed a sample size of 276 patients in each group to give a power of 95 or 91%. And then as far as their secondary outcome, trying to find superiority in terms of the FEV1 area under the curve, they found out they needed a sample size of 736 with 368 randomized to each group to get at least a 90% power to detect that 60 ml difference. And they used a mixed model with fixed effects being treatment, smoking, status, exacerbation history, baseline ICS use, and region. So I'm just going to quickly kind of go off the path here and just talk a little bit about a little quick review on non-inferiority trials and what we should kind of be looking at them when we review non-inferiority trials. So basically, it's, as we all know, it's a way a new treatment's effectiveness does not have to be substantially worse than the standard. So it's different than an equivalence trial, as the equivalence trial, you're looking for the study drug to be neither better nor worse, where with non-inferiority you don't care, you just want to make sure it's not worse, substantially worse. It's often used when the standard treatment has significant harms or burdens. In our case, we could presume that the ease of a combo inhaler done once a day, that would be kind of a burden, compliance-wise. And then also, as we know, there is an increased risk of pneumonia in patients on ICS. As far as acceptable non-inferiority thresholds, there's no really universally accepted method to come up with your threshold. And so when you're reviewing the study, you have to basically decide if you think that's a reasonable threshold or not, if you think that's a meaningful different or not, and it needs to be part of the education with the patient when you're deciding on treatment. But basically the way they did it here, like I kind of reviewed, is they looked at a Cochrane review about placebo versus Advair and what the smallest plausible benefit from the standard is, and that was 120 mLs. And then you want to preserve at least 50% of that minimal treatment effect, which is common with drug regulation, so then you get the half of that, which is the 60. You also want to make sure you're guarded against unwarranted conclusion of non-inferiority, which basically what I mean by that is when you're enrolling patients, you want to make sure they're not getting suboptimal treatment, i.e. you're enrolling patients who are non-compliant, people who are at low risk for an effective outcome, so then basically, your actual treatment is not preserved compared to other trials of your standard of care. So moving back to our study, over 1,000 patients were screened and 744 were randomized, 372 to each group. So looking at the results, these are the patient characteristics, and I've highlighted, I know it's kind of small, probably hard to see, but I've highlighted the three that kind of stuck out to me as somewhat significant. So as you can see, male sex, it was predominantly male sex, like 90% of the patients, which I thought was very odd. I'm not really sure why that was. Most were also Asian, which was over 80%. It was conducted mostly in China as well as Taiwan, so that makes sense as far as that goes, but very male predominant. And then if you look down at the exacerbation history, most patients had 0 exacerbations. So people at potentially lower risk, between 70 and 80%. So this graphic shows their primary outcomes. So it's the trough FEV1, and you can see it at day 1, week 12, and 26. Their primary outcome being at week 26. And this is using the full analysis set, which I'll get into a little bit later. But the purple is the salmeterol fluticasone at the 500 dose, and then the blue is our study drug LABA/LAMA. And you see there is it was a statistically significant improvement in the trough FEV1 at all time points, but if you can see it at 26 weeks, which was our primary endpoint, it was by 75 milliliters. So yeah, it's better, but kind of take it with a grain of salt. 75 isn't a huge amount when we look at day-to-day people's spirometry and how they vary. This is just a forest plot of the treatment difference in the different subgroups, and you can see pretty much all of them favor the study drug, and they break it down, like I said, based on age, smoking. You can see their COPD, severity, and then baseline ICS use and COPD exacerbation history. And you can see the one that has a pretty large range here and comes close to dipping over across the line here is the exacerbation history, which, like I kind of mentioned, a lot of the patients in this group did not have, exacerbation histories. It was like 70 to 80% had not had one in the past year. Now looking at the secondary endpoint, the FEV1 area under the curve, you can see the treatment difference at day 1 and week 26. Week 26 being their secondary endpoint, with the improvement with the combination drug at week 26 being 122 milliliters. So, and then just kind of diverge a little bit in case anyone's unfamiliar with the terminology of this area under the curve. So it's commonly comes up in a lot of our COPD trials and asthma trials. So it's basically just the area under the curve of the time FEV1 curve, and then you can divide it by the time to report it in liters. It's just like an aggregate effect over a period of time, and I think it was just kind of sort of an average of that time. And then just kind of wrapping up some more results for the Lantern trial. The TDI scores, so that transitional dyspnea index score, didn't show any statistical difference between the groups. The St. George's Respiratory Questionnaire also didn't show any statistical difference between the groups. And then use of rescue medication was comparable between the groups, and as we all know, that's one of the things we commonly ask our patients to try to assess, like how well they are controlled. And then the CAT scores were also comparable between the groups. And the patient recorded symptoms, because they had an e-diary that they record their symptoms in, were pretty similar between the groups. This just shows the annualized rate. It was one of their kind of exploratory endpoints of moderate to severe exacerbations, and they were significantly lower with the LABA-LAMA combination, with a 31% risk reduction. This little graphic just summarizes the number of exacerbations in the two different groups. And this looking at safety and the side effects. The left graphic basically just shows the percentage of patients that required hospitalization with all their side effects, and then COPD exacerbation requiring hospitalization and pneumonia. And on the right here, you can see I've kind of outlined the one that has the biggest kind of difference in side effects, and would be important for us, is the percent of patients who had pneumonia in the two different groups. So you can see that the one with the ICS had 10 patients at 2.6% versus 3.8%. All right, so sorry if I'm moving kind of fast, but I have a whole other trial to get through. So just kind of going through the discussion just to kind of wrap it up for the Lantern trial. The primary endpoint was reached with the non-inferiority of the study drug by trough FEV1 at 26 weeks, but it also showed superiority. But the difference, like I mentioned in a previous slide, was only 75 milliliters, so you kind of take that with a grain of salt if you think that's really, significant for our patients. And it didn't translate to better symptom control, as I mentioned. All the, questionnaires and patient-reported symptoms, there was no difference between the two groups. And so we're using this kind of surrogate of the FEV1 trough as, I guess, potentially surrogate for disease progression. But like I said, once again, it didn't translate to symptom control. And like mentioned before, it does make sense that having two bronchodilators of different pathways, you're going to have better bronchodilation. So it's really not surprising that, the spirometry is going to be improved with two bronchodilators versus one. And also, it's, as we all kind of know, that it's thought that ICS use is potentially more beneficial in patients with frequent exacerbations. And they weren't really included in this study. As I mentioned, there were like 70 to 80% of people had 0 exacerbations. So some of the strengths, it was a pretty large study, multi-center, although primarily done on Asian patients and male patients. It used trough FEV1, which, like I mentioned earlier, is important due to the twice-daily dosing of the comparison drug. And it confirmed and expanded on a lot of the previous trials, and most importantly, the one that came right before it is the Illuminate trial. So limitations, it was 6 months, so it's a little bit longer than some of the previous trials, but it's still relatively short in the long term if you think about our patients with COPD. Like I mentioned, the study group was male predominant and Asian predominant. It excluded patients with significant comorbidities, so I don't know how applicable it necessarily would be to all of our clinic patients. It also included some of the more sicker patients, like I said. So if your FEV was less than 30, you weren't included, or if you had more than one exacerbation in the last year, you weren't included. And it did use per protocol analysis for their primary endpoint, so that's something to keep in mind. All right, so moving on to our next trial, which is the FLAME trial, which is once again part of the IGNITE group of studies. So this study design was also, I don't know why I put 26 weeks, it's actually 52 weeks. So this was a year-long study, so longer. Also a multi-center, randomized, double-blinded, double-dummy, parallel group, non-inferiority, and it was conducted in 356 centers in 43 countries. Patients were randomized between July of 2013 and September 2015. And they were randomized once again, 1-to-1, so same grouping of indacaterol and glycopyrronium and salmeterol fluticasone. What was interesting and different about this study is, so it also has this washout, 1 week washout, and then it had a 4-week run-in period, and during the run-in period they put everyone on tiotropium. So they took them off during the washout screening period of whatever they were on, and then they put them on tiotropium the month leading up to randomization. So for its inclusion criteria are pretty similar, at least 40 years old. They wanted you to have stable, quote-unquote, stable COPD, MMRC greater than or equal to 2, current or ex-smoker with at least 10 pack years, FEV1 for this group, a little bit different ranges, between 25 and 60, so a little bit sicker patients. And you had to have at least one exacerbation in the last year requiring systemic steroids and or antibiotics. And they required that your COPD medications had to be stable the 60 days prior to screening. Exclusion criteria, kind of the same for the general exclusion criteria. They just didn't have the BMI in there, greater than 40. That was pretty much the only difference I could find. And then as far as the COPD specific exclusion criteria, the main difference in this, you just couldn't have had an exacerbation with requiring antibiotics and or steroids or hospitalization for the last 6 weeks. But like I said, you could be rescreened and potentially randomized. Other than that, all the rest was pretty much the same as far as the history of asthma. The eosinophils greater than 60 or 600. So outcome measures, primary outcome was also a non-inferiority of the study drug to salmeterol fluticasone in reducing the rate of COPD exacerbations. So this one now is focused more on COPD exacerbations, whereas the Lantern trial was a spirometry-based trial. So the primary outcome was the annual rate of all COPD exacerbations, and the secondary was superiority of the above. Some other secondary outcomes, there were 26 or 27, so there were a lot, but ones I mentioned here seem more significant are time to first exacerbation, trough FEV1, the FEV1 area under the curve, and then looking at health status, looking at the St. George's Respiratory Questionnaire, and then use of rescue medication. For statistical analysis for this trial, they set an inferiority margin of 15%, which corresponded to a rate ratio for exacerbation of 1.15, and this was based on previous study, the TORCH trial. So basically what it was is the fluticasone salmeterol rate ratio of 0.75 on moderate to severe exacerbations versus placebo from the TORCH trial, then assumed that the annual rate of exacerbation of this was 0.75 and placebo was 1. So therefore, if they ruled out 15% higher rate of exacerbation in the study trial, they would subsequently say that versus placebo, there would be a 13.75% reduction in rate of exacerbation of the study drug. So they studied modified intention to treat population. So all patients who underwent randomization were included who received at least one dose of the drug treatment and didn't have any major violations of compliance. The per protocol population was all the above patients who did not have any major protocol deviations. And then the analysis of primary outcome was done on the per protocol population. This is probably very small for you to see, but quite a bit bigger trial than the last one. There were over 5,000 patients screened, and then 3,362 underwent randomization. But then if you look down towards the bottom, you can see how many patients were excluded during the run-in and washout period. If I can see it on here. So there was almost like 1,000 patients total, I want to say, that were excluded. Oh no, I'm looking up here. So if you look between the run-in period and the randomization, you can see there were over 1,000. There were like 1,600 that ended up not meeting the criteria. But then as far as if you drop down after randomization, people that were included in the modified intention to treat and the per protocol analysis were still relatively large numbers. So looking at patient characteristics with this was also pretty male predominant, but lower than the last one in 70% range. And looking at all exacerbations, with the rate ratio, there was a 11% reduction in the study drug versus the salmeterol fluticasone during the 52 weeks of the whole year of treatment. This is looking at just all of them, not categorizing them by severity. And then this is looking at all exacerbations as well, just looking at it kind of in a different graphic. With your superiority margin and your non-inferiority, so you can see that they met not only non-inferiority but superiority, so they met their primary and secondary outcome. And you can see that they also showed the per protocol and the modified intention to treat, and they both agreed, so that's reassuring that they're going in the same direction there. This is kind of a big graphic too, but I wanted to just show the subgroup analysis of all exacerbations as well, and they're all pretty much favoring the study drug. You can see the ones that aren't as in favor are the very severe COPD group and the patients who have greater than equal to 2 exacerbations. So even though they included these sicker patients or more sicker patients in this group, you can see that that's where kind of the evidence isn't as strong. So then this is looking at the FEV1 trough and then the area under the curve. So on the left you have the trough FEV1 and on the right you have the area under the curve, and this is all at 52 weeks. And you can see the pink once again is our Advair and the blue is our study drug, where the trough FEV1 there was a change of 62 milliliters was the difference. Treatment difference, and then with the looking at the area under the curve of the FEV1, it was 110. So now going into some of their other things they looked at with the St. George's Respiratory Questionnaire scores. So they mentioned that there was an improvement seen in the study drug, but they didn't reach what we call the minimal clinically important difference between the groups, which for this questionnaire I think is at least a change of 4. So there wasn't a 4-point change with this score, so probably not that significant. And then as far as the use of rescue medication, there was a difference, but it was by a fourth a puff per day. And there was an increased percent of days with no rescue med use, which is 13 versus 8.3%. And then they also controlled for or looked at eosinophils, and the rate of exacerbations were similarly significantly lower in both groups. They used a cutoff of 2%. So they only used percentage, but however, the absolute, they were excluded if they had greater than 600 from the study anyways. So moving on into discussion. So like I said, the primary endpoint was reached. It also showed superiority. Most were mild exacerbations, though. However, I think it was like 70 or 80% were mild exacerbations. And there was, however, no superiority was found in the annual rate for severe exacerbation, because they did break it down into like moderate, severe, and severe. But it was a smaller group, so the study really wasn't powered for this, so I don't know if we can really ding them for that. And once again, there was improved bronchodilation as expected on a dual bronchodilator. And then the question for me is kind of like, it didn't really translate to patient-reported quality of life with, this SGRQ. So strengths, it was a large study, even quite a bit larger than the first one we went through. Also multi-center. Was male predominant, but not as much as the previous one. It did look at the relationship of exacerbations to eosinophil counts, which was kind of nice to see. It only used the percent, not the absolute. But like I said, if they had greater than 600 absolute anyways, they were excluded from the study. And the study group did include a high percent of Gold D patients that were previously recommended for LABA ICS therapy. So that's kind of where all this sort of data and paradigms change is coming from. And it included more patients with exacerbation history. So it didn't allow patients, you had to have at least one exacerbation to be in this study, but there were still very few that had, at least 2 exacerbations. And like I mentioned, it did include more patients with higher degree obstructions. Overall, kind of sicker patients. Limitations, so like I mentioned earlier, the run-in phase may cause a selection bias, so it was potentially selecting more compliant patients. There's a question I have. Many patients were eliminated during that washout screening period, as we saw over 1,000. And the superiority analysis was done on the modified intention to treat population, although like I mentioned before, these size comparisons were pretty similar. It was only off by, about 10 patients of the greater than 3,000 randomized. So probably not that significant, but I thought it's worth mentioning. And then I kind of questioned the level of the industry involvement. Obviously, in all these trials, they're all funded by industry, but it mentioned there was just this one line in the paper when I read that just kind of stuck out to me, how, it said Novartis performed trial monitoring and reporting, provided insight and verified results, and anything else they deemed, or didn't have other, it was just very weirdly worded that I was like, well, it sounds like they pretty much were completely involved in everything then. And then they didn't, another point to bring out, neither of the trials actually reported any side effects of typical anticholinergics, although they did exclude high-risk patients, so maybe that's why they didn't include it in their safety profile. And once again, like I mentioned, still, though they had sicker patients in this study, most exacerbations were still mild. Greater than 70% were considered a mild exacerbation. So, not that they're not significant, but, mild meaning they weren't requiring steroids or antibiotics. So,
Who would define it as mild, moderate, or severe? Was it?
So the way they did it is they had an e-diary where they would track their symptoms in the morning and at nighttime, and depending on what showed up in there, it would trigger them to make an appointment with the investigator, the study trial center, and then it was up to their kind of discretion, if they thought that they required, maybe, because mild basically based on our criteria is, not requiring steroids or antibiotics. Moderate is steroids or antibiotics, but not requiring hospitalization or ER visit less than 24 hours. So if it was severe, they were in the hospital greater than 24 hours, and moderate was, at least had some sort of systemic treatment, and then mild was basically no treatment, but they had a change in their symptoms. So that's kind of how it got triggered. And then they said if anyone was treated with steroids or antibiotics but didn't fulfill the criteria as far as symptoms for an exacerbation, like they didn't feel like it felt that criteria, they still categorize it mild. Does that make sense?
Yeah, it did. It's fuzzy.
Yeah. Because up to kind of your discretion. So let's just kind of briefly summarizing the 2 trials side to side. They both met their primary endpoints. But the primary endpoint with lantern was spirometry-based versus exacerbation-based with flame. It was a smaller study versus a larger study, shorter duration versus longer duration, so 6 months versus a year. and they had less severe disease in Lantern and more severe in Flame. And basically the recent Cochrane review that's out and the new GOLD guidelines really mirror kind of these results and the change in recommendations for first-line treatment, especially in those group C and D patients. So I know there's probably going to be a decent amount of discussion going forward after this, but it's kind of my kind of final thoughts. So neither study found any statistical significance in patient-reported symptom scores. So, I mean, obviously exacerbations and spirometry are paramount and important in assessing COPD patients. But if the day-to-day the patient doesn't really feel that much different or significantly different, then I just think that's a big point that it really didn't pan out. And then the applicability to our typical clinic patients. So a few things. As I mentioned, a lot of the patients that were excluded due to significant comorbidities, and I feel like we get a lot of really sick patients, and a lot of our patients have a lot of comorbidities, and it's kind of realistic in real life. And then a large majority of the patients in both these trials were male predominant, and then in the first trial were Asian predominant, so kind of take that with a grain of salt when you're trying to apply this to our typical patients. And then I questioned cost effectiveness and affordability. It's hard enough for us to get, any kind of inhalers for our patients, let alone these brand new ones that really aren't even brand new. They're just kind of putting a combination of two medications, in one. And then, I questioned, well, how does this kind of like fit into our strategy, and should we be taking all of our stable COPD patients who are on LABA ICS and switching them to LABA LAMA? I mean, I don't think anyone knows. I think personally, if someone's stable on what their regimen they're on, I'm probably not going to switch everything up. So I think that it's more applicable to the new evaluation of patients and thinking a little bit more about where you start them on therapy, not just jumping to, the previous combo drugs that we used to use. And then in the future, as we all are probably waiting for and assuming is going to come shortly, is when we're going to have an inhaler that has triple therapy in it. And then, after discussing with Dr. Ouellette, isn't it time to try to look for some new drugs and do something else instead of just taking all these different drugs and creating new drugs that are in the same class and just combine them in different ways and kind of getting the same result? I feel like.
Can you go back to your last slide? One before this one. So there's two studies here, right?
Mm-hmm.
And both studies had the same study drug, and both used the same comparator drug.
Mm-hmm.
And they were both studied or funded by the same company. So why did they do this? They did this most likely because the FDA required them to do two similar studies with the same drug in order for them to get FDA approval for their new treatment. So we tend to look at this data from a perspective of taking care of patients. These two studies are done so they can get their drug approved. That's what this is all about. And they let the people, the physicians who are involved in conducting the study write these articles, but that's their goal. And so we should think about this a little bit in terms of what they're trying to do, which is to get their drugs out there on the market.
But they also separated severity of disease because I think they weren't sure
They
if it would work in both.
So I totally agree
Yeah.
that they looked at different endpoints and they had slightly different patient population, but I am certain the reason that they did two very similar studies instead of tens of millions of dollars doing these two is to get their drug out there.
But typically those are combined, for the fibrosis trials, they're now combined as the two trials will be combined into one publication. We'll show the data for them separately. But these populations are slightly
If they
different.
can get it published in two different publications, they'll do it.
I mean, they've got 11 publications here on the same trial drug.
That's what they'll do. So sometimes that's a publication issue. That's not what the FDA requires. The FDA requires two.
But they would say it had to be the same population. So there was a reason they separated out milder disease from more severe disease.
There may have been specifics by the FDA, but I'm sure that the reason there are two very similar studies done in this way is to get those drugs out there and approved.
I thought go ahead. It was kind of interesting that compared to the TORCH trial, which did not meet its primary endpoint, which is a survival trial, and not actually, you do better type trial. And what's kind of interesting because then these positive trials with Advair comparing to a single agent, Ceravent or just, LAMA showed non-inferiority there also.
because they are
And so now we're combining those two drugs
Yeah.
with non-inferiority, so that brings up the question, is the combination really any different than one alone?
Well, they're arguing to the FDA that this previous combination is standard therapy now for COPD, and so we want to compare this new combination to the standard therapy to show that our drug should be approved.
Well, it's been shown that Advair was just as good as one drug previously also. And yet they got these two drugs showing comparability to Advair, so, it's kind of all
I think
advertising.
my only concern is that it's not answering my question. That is, if I have a patient on Esperiva and I want to add something, in this case could be Advair or could be one of these new drugs, it's the Alto, is that better, the same or not? But because they are just comparing Advair against ipratropium plus Alava. So I think that's the only thing that I don't like about these trials, is that it would be nice to have like the three drugs compared to the new drug that is excluding the ICS and see, because I think the TORCH trial, they showed at the end that the combination of three was decreasing hospitalization, so that's the only thing.
I'm still not convinced this is better than LAMA alone.
Yes.
I mean, the previous ones I went through were all comparing that, and they all had, significant improvement, but I think you weren't in here. So I first went over just a LABA-LAMA one, so a lot of them had just like LABA versus combination or LAMA versus combination, and so they were all favorable, I mean, with not huge differences, but.
You don't know whether to use an inhaled corticosteroid LABA combination versus a LABA-LAMA combination. You're not sure whether you would use one.
Yes.
I know.
Because the usual step up is,
Kind of take your pick.
our usual step up is you just add ICS lava. And then
Well, if you look at the gold guidelines from this earlier this year,
I'll go to it.
they brought in this entirely. So they're looking at LABA-LAMA combinations is really the early thing if the LAMA doesn't work. And so
Yeah, this is what they're
when you
telling us to
think
do.
about the fact that the guys who are doing gold guidelines were involved in a lot of these studies, then you really have to wonder what's going on a little bit.
Are you guys finding there on anybody's formulary, this LAMA-LABA combination, when you're writing for them?
Don't write from very much.
I didn't either, but I think it's been a struggle,
are we going to change practice? Is this, I guess my question is, does this have enough in it that, if I have a patient not doing well on titrating alone, and I'll go LAMA-LABA?
I guess for me, I think it's partisan hairs a little bit, but I think for me, there is an increased incidence, although small, of respiratory infections with inhaled corticosteroids. Inhaled corticosteroids is not a true bronchodilator, and so I start to wonder whether or not, if I have to add a second agent, whether that shouldn't be allowed instead of an inhaled corticosteroid. I'm beginning to wonder about that. But
I think if we do that, I think these studies do bring up is to say things, talk about things at least I don't talk about in clinic with fellows or think about myself, which is, did the patient have any symptoms before the age of 40? What does the patient see eosinophil count? And because you have to make sure you're excluding anybody with sort of an asthmatic phenotype. And because our disease treatments have been somewhat nondescript in that we've been adding ICS very frequently, I haven't thought about it as much, but
the reason
probably need to do that.
It's kind of interesting. The reason I think they included the eosinophil thing was not just to exclude people with asthma. There's some emerging data that show there's increased exacerbation rates among COPD patients who have elevated eosinophil counts. There have been some studies that have looked at that group in particular, and there have been hypotheses that these people should be the ones that we treat with inhaled corticosteroids, but that's also not been really proven. But I think they were looking at that number to try to learn, to see if they could find out any more about that. I don't think they did, really.
They did. They studied the LABA-LAMA and the LABA-ICS had similar exacerbation rates.
That's what I mean, though.
The eosinophil counts less than or greater than 2%.
That's what I mean. So some studies have shown that there's a difference in exacerbation rate. They didn't show that. I think that's why they included it, to see if there was a difference in rates, and they didn't see that.
So even with the asthma phenotype, theoretically, a lava would offer you the
Well,
same
what I'm
coverage.
saying is I'm no longer convinced, and there are some other people who think that that doesn't simply indicate an asthma phenotype. There are some people
Agreed.
that it actually is a marker in COPD that we haven't really been looking at.
But again, Mike, remember, this is in a subset whose absolute eosinophil count is always less than 600.
Right.
So yes, they had more than 2%, but they couldn't have had more than 600.
Yeah, but how
There was a pro-con at ATS in which they presented other studies that showed very similar data in even individuals with greater than 600 eosinophils.
Well, you mentioned the respiratory infection rate too, which I thought was kind of interesting, that in Galera and Advair, there's an increased incidence of pneumonia that you never see in Symbicort in the studies, which I've always wondered, does that mean because Symbicort's not as potent a drug as the other two, but you don't see it in that one?
Good points. I just thought I'd make this slide too to kind of clarify what's out there, what's sort of available, and the different names, because there's just so many new drugs coming out. But
Is there am I the only one who's presenting some disconnect with someone who, if they call an exacerbation mild, and they say that there's no change in symptom?
well, that's not an exacerbation.
What does that mean? So.
Well, they shouldn't be an exacerbation if there's no change in symptoms. So, like, their E-diary would get their symptoms. So if they had at least, two things of, cough, increased cough, purulence, dyspnea, they had at least two of those criteria. But if they didn't require systemic steroids or antibiotics, then they remained mild. But if they required treatment, they were moderate. And if they required hospitalization, then they're severe.
I guess what I'm thinking of is if the one group has, 70% less mild exacerbation, the patient would have perceived those as, an improvement compared to the other group. You know what I'm saying?
Oh, I see what you're saying. So,
Their St. George respiratory.
right, so
Because
they,
they're almost like the same questionnaires if you
Yeah.
break it down. So I was a little confused about
yeah,
that.
so they're like recording on their daily thing that it's flagging they had an exacerbation, but when they actually do their questionnaire,
yeah,
it's not
so-
reflecting that, I had an exacerbation last week, or, yeah, I don't know why there's a disconnect
It
there.
has something to do with the threshold of whether a St. George respiratory questionnaire actually
Bigger.
calls something as being different.
Maybe that 4.
It's
Four.
4, is 4
Yeah.
points,
So
so,
you might, which is like, that brings up the question, so 2 is enough to trigger an exacerbation, but if you don't have a change of 4, it's not significant.
yeah, I think it's 4, I have it on here somewhere. Yeah, 4 units, so.